So let's get started. 34-year-old female with known history of myasthenia gravis presents to the ED with fever and cough, compliant with her medication regimen, denies any reports of exacerbating symptoms. Chest X-ray shows lobar pneumonia. Which of the following antibiotics should be avoided in this patient to prevent myasthenia gravis exacerbation? So we'll just do show of hands. Don't be shy. A, azithromycin. Anyone for azithromycin? B, levofloxacin. Excellent. C, Bactrim. D, all of the above. Or E, none of the above. So it's actually all of them. So really fast, myasthenia gravis, you have autoantibodies against the postsynaptic acetylcholine receptor, which can cause weakness, especially with repetitive movements. Some of the classic symptoms, you could get ptosis. They can have this expressionless face. They call it the myasthenic sneer. Basically, patients try to smile and the corners of their lips won't go up. And that's because of the orbicularis oris muscle. They could have muscles of the jaw closure also get weak. Sometimes their jaw hangs open because they can't keep it closed. Neck extensors can also get weak, so they could have this dropped head syndrome. They could have proximal muscle weakness, and then the worst case, which is their crisis, is when their diaphragm starts to become weak as well from repetitive use. This picture was in the reading, lots of different medications. The ones that are asterisked are just from case reports and case studies, so not specific, not as specific as some of the ones that are more well-known, but this is just a reminder that if you do have a patient, just double check what medications to avoid. So you'll see here the fluoroquinolones, sulfonamides, which is Bactrim, and macrolides are all things to be wary of and cautious of. Question 2, a patient presents to the ED awake, but appears confused and not responding when you call their name. They are noted to be repetitively swallowing and smacking their lips. You suspect this is a type of seizure. Which of the following best describes this type of seizure? Generalized tonic-clonic, partial focal, complex clonic, partial complex, or absence. So anyone for A? Anyone for B? Anyone for C? D? And E. Good. So yeah, partial complex. So I know a lot of times we think seizure, we all think generalized tonic-clonic, but this was just kind of a reminder that seizures can present a couple different ways. Quickly, they're just, they're split into partial and generalized, and this classification is from the ILAE, which is the International League Against Epilepsy. So partial is when the activity starts in one area of the brain. And it's actually interesting because depending on what part of the brain it starts in will depend on what the symptoms are. So it could be in the frontal lobe, which can be a couple like more motor-like symptoms because your precentral gyrus is there. Whereas your temporal lobe, you could get smell if it's in the uncus, fear or anxiety symptoms if it's in the amygdala, and even like a deja vu if it's in the hippocampus. Parietal symptoms, more sensory because that's where your postcentral gyrus is. And then occipital, you could have almost like visual hallucinations, but it's actually a seizure. Simple means they retain awareness, whereas complex, they become altered and unresponsive. And then you could have secondary generalized, where it starts in one area, but then can progress to generalized. So generalized is when the whole brain is involved, and that can be broken down into like the tonic-clonic, absence, tonic, or atonic, which is also known as a drop attack. Basically, they kind of lose tone. I'm sorry, they could either like fall and either be found to have loss of tone, which is atonic, or very rigid tone, which is tonic, versus myoclonic. And I learned going over this, the difference between myoclonic and clonic is that myoclonic are sudden, like brief muscle jerks. And if they do it repetitively, it's considered clonic. 3, 35-year-old male presents to the ED with lower extremity weakness, gradually worsening over the past 1 to 2 weeks, says he normally exercised daily, but has been having more difficulty lately and could barely go for a walk the past few days. Now he can't walk unassisted. He was in his usual state of health prior to these symptoms, other than a mild cold a few weeks ago that self-resolved. Vital signs all look okay. Which of the following is the most preferred treatment? Cefepime, linezolid, and acyclovir, corticosteroids, eculizumab, pyridostigmine, or IVIG. So how many for A? B, C, D, or E? Excellent. So this is GBS. So it's an acute immune-mediated polyneuropathy. The pathophys is basically an immune response to a preceding infection that cross-reacts with peripheral nerve components, and usually we say it's due to molecular mimicry. So this is a very general kind of concept because a lot of different variants exist for GBS, but as per up to date, the only required features for diagnosing GBS is progressive weakness of the legs or arms. It's more suggestive if it's symmetric, and also areflexia or decreased reflexes in the weak limbs. But again, there are multiple variants, and I believe there is one that reflexes are actually preserved. So this is just in general. What happened? Oh, there we go. There are some associated symptoms that they're not required for diagnosis, but they can be more suggestive of the diagnosis. So you can see how often or how common these symptoms are associated. And then again, the diagnosis is clinical, but there are some studies that again can suggest it. They're not required for diagnosis though. The only thing I really want to highlight here is the treatment. In severe cases, you'll give IVIG or Plex. They're similarly effective. IVIG is easier to give, and Plex is more likely to be discontinued due to adverse side effects. So it's just easier to give the IVIG. And I also learned that if you give both of them, the combination is not better than each of them individually. 28-year-old female with a history of migraines presents to the ED with gradual onset worsening headache for the past 6 hours. She says it feels similar to migraines she's had in the past. She endorses nausea, denies vomiting, weakness or paresthesias. Physical exam is unremarkable. You decide to treat her symptoms, treat her symptomatically with fluids, Tylenol, Toradol, metoclopramide. Her symptoms resolve a few hours later. You're planning to discharge her when she yells for you and the nurse because she feels incredibly restless, agitated, and her neck starts to spasm. On reassessment, ABCs are intact, vital signs are stable with the exception of a heart rate of 105. What is the next step in management? Benadryl 50 IV, Solumedrol 125 IV, Valium 5 IV, Flexeril 5 PO, or morphine 4 IV. How many for A? B, C, D, E. Great. So here we have a side effect of the metoclopramide. So extrapyramidal syndromes, akathisia, dystonia, Parkinsonism, and tardive dyskinesia. Akathisia is more of like your restless anxiety, agitation type symptoms. Dystonia is more of the involuntary limb muscle movements, which is what I tried to describe akathisia and dystonia overlapping in the question. You can get some Parkinsonian symptoms like bradykinesia, tremor, rigidity. And then the worst of it all, from what I remember, is the tardive dyskinesia, the disfiguring involuntary movements of the face, tongue, trunk, and extremities. Yeah.
My experience actually has been that often when they get the sonic reactions, it won't be till the next day, and then they'll come back.
Yeah.
Something has to happen in the metabolism, and I'm not sure what, to make them have it. And once they get it, even if you stop the med they're getting, you stop their Haldol, or they only got one shot of Compazine or one shot of Reglan, it can last up to 5 days. You always want to send them home on something, even if you stop the med that they're getting.
Mm-hmm.
And you have a choice. You can send them home on Benadryl, but they may be sleepy. Or you can send them home on Bentropine, which is Cogentin. But always send them home on something for 5 days before they come back.
So I'll kind of reiterate what Dr. G says in the next 2 slides. So he said usually he sees that some of these symptoms happen after the first 24 hours. Sometimes they come the next day. So for the dystonia and akathisia, it is relatively rapid, usually within the first 48 hours. And then the Parkinsonism and the tardive dyskinesia can actually be up to several months after. Multiple risks, high doses, longer duration of therapies, ages, renal impairment, et cetera. And the treatment, Benadryl 25 to 50 IV, benstropine as well. And Dr. G was also mentioning that if the treatment is successful, you continue that treatment for several days, about 5 days after. All right, 30-year-old female with no known past medical history presents to the ED with a non-productive cough, congestion, rhinorrhea, and subjective fever at home for the past 3 days. On review of system, she endorses changes in her vision over the past 3 days, as well as tingling in her legs about 2 months ago that self-resolved. She denies any trauma. Vital signs have a temperature of 100.8. Otherwise, they all look okay. Physical exam notable for delayed extraocular muscles, but they are intact. Otherwise, remainder of the exam, including the rest of the neuro exam, is unremarkable. Labs show a white blood cell count 15,000. Otherwise, the rest of the labs within normal limits. Aside from treatment for the presumed infection, what additional treatments should be administered? Acyclovir, oral prednisone, vitamin C, IVIG, or methylpred. And pay attention to the doses. So how many for A? B, C, D, or E? So it's actually high dose steroids. You can give methylpred, solumedrol, but it has to be 500 to 1,000. And 1,000 of methylpred is equal to 1,250 milligrams of prednisone. So this is describing MS, suggesting MS. I'm not going to go into like the nitty gritty details of like all of the, there we go. But I just want to emphasize that it's multiple neural lesions that are kind of divided across space and time. Pathophys is generally inflammation, demyelination, and axonal degeneration. So see, these are some of the findings that are suggestive of it. This slide is just to emphasize how complicated it could be to diagnose, but just something to consider in the back of your mind if somebody has these funky like neuro symptoms that don't quite line up with what you think the diagnosis is, and if it's something that they've had in the past. So you could give prednisone or methylprednisolone. The goal of the treatment is to speed the recovery time from the attack, but the acute treatment doesn't have any apparent benefit for improving long-term disability or reducing subsequent attacks, unfortunately. The other thing I just want to emphasize is that you'll give these after the infection, the acute infection resolves. You don't want to give them during the acute infection just because of the immunosuppressive effects of steroids. So like I said, methylprednisolone is, the dose is either 500 to a gram daily, and you'll give that for about 5 days. Or you could give prednisone, which is 625 to 1.25, I'm sorry, 625 milligrams to 1.25 grams, also daily for 5 days. Because the conversion from oral pred to solumedrol is about 1.25 to 1. And there is a calculator on MD Calc, just in case you didn't believe me.
To know is that the different steroids, milligram, have different strengths. So for example, if you count hydrocortisone as 1, prednisone would probably be 4 times as strong as that milligram, or the change in the dose. And then methylprednisolone would probably be at a level of 5, and dexamethasone would be at a level of like 20 almost. 20.
Question 6, 7-year-old male presents to the ED brought in by EMS with pain and deformity to the right upper extremity after falling while going downhill on his rollerblades. He's crying loudly and holding his arm. Radiographs of the, that's supposed to say upper extremity, right upper extremity are showed. What's the most common type of nerve injury associated with this fracture? We have anterior interosseous, radial, ulnar, musculocutaneous, or axillary. So how many for A? B, C, D, or E? So it's actually a branch of the median nerve. Anterior interosseous is one of the branches of the median nerve. And this here is talking about a supracondylar fracture. A lot of times when we see supracondylar fractures, at least in my limited experience in the PDD, they're usually type 1, which is non-displaced. And you really, the clue on the x-ray is your posterior fat pad, which is pathological. Type 2 is when you have displacement in one plane. It's usually the sagittal plane. Type 3, it's displaced in 2 or 3 planes. And then type 4, there's complete periosteal disruption with instability, inflection, and extension. And that's truly only diagnosed in the OR under anesthesia. So your anterior interosseous nerve innervates the lateral half of the flexor digitorum profundus, flexor pollicis longus, and the pronator quadratus. So you do the OK sign. These muscles will cause flexion in the interphalangeal joint of the thumb and the distal interphalangeal joint of the index finger. So I think I kind of circled it. Yeah, so these two joints right here are the joints that should be functioning. And if they can't, you'll notice that they kind of stay straight and they can't make an OK sign. If you're not sure, you can have them like hold their hand up and you can try to like pull on it. And if they can't like keep their knuckles together, sometimes that's another clue. And there's no loss of sensation associated with this nerve. Radial nerve is a close second. Sensation is lateral dorsum of the hand. And motor wise, you're looking at the wrist extensors and thumb abduction. So they will not be able to extend their wrist, their MCP or their thumb interphalangeal joint. The PIPs and DIPs are still intact because of ulnar nerve innervation. And then the median nerve innervation is lateral palmar surface of the first 3.5 fingers, and motor is opposition. And usually once the injury is quickly reduced, the nerve dysfunction resolves spontaneously. 20-year-old male with no medical history comes to the ED with fever and headache for 8 days. Comes with his college roommate who says he's been acting differently the past few days, doesn't seem to be getting better. You're suspicious of meningitis, so you perform an LP in addition to blood and urine studies. Which of the following CSF results would suggest a bacterial etiology? I'm not going to read all of them, but so anyone for A? Anyone for B? Anyone for C? Or D? So yeah, B is correct. So I feel like we've all probably seen this question and this has been drilled for a while. So a little back to basics here, but a couple things you look at, obviously the gram stain, I didn't include that in the question because it would have made it a little too obvious, but cell count, glucose, and protein. So B was your bacterial. You could see the normal values are in the top row. A is actually normal findings or can be normal. C is more suggestive of viral because your glucose is normal and your protein is slightly decreased. Actually that, oh yeah, never mind. I thought I had a typo. And then D is more suggestive of your fungal. Question 8, 6-year-old male, history of hypertension, hyperlipidemia, diabetes, prostate cancer, brought in by EMS with acute onset of weakness and decreased sensation from the umbilicus to the lower extremities. While in the ED, he has an episode of urinary incontinence, which he has never had before. He denies any trauma or falls prior to arrival and states this all happened suddenly while he was at home. Vital signs are stable. On exam, he's ANO ×3, cranial nerves intact. He has 5 out of 5 strength of the bilateral upper extremities and 0 out of 5 strength of the bilateral lower extremities. He's unable to identify where you are poking his lower abdomen with a sharp object, but he could feel light touch and vibration sensations. Which of the following is the most likely diagnosis? We have central cord, Brown Séquard, anterior cord, cauda equina, or a complete transection. So how many for A? How many for B? How many for C? How many for D? And how many for E? So I guess I should have started this with I'm not that good at writing multiple choice questions. So some people pick D, but I was going more for C, anterior cord syndrome. So a couple things, a couple different mechanisms that could cause each of them, but I'll have a more of a visual later in the slides. But it depends what part of the spinal cord is kind of knocked out. So let me kind of skip ahead to that. I should have put that slide first. These are your dermatomes just for reference. But this is what your normal spinal cord is. You have your dorsal columns in the posterior side, which are your proprioception and vibration sensations. And your cortical spinal tracts, which are your motor fibers, and then your spinal thalamic tracts, which is pain and temperature. Oh, I messed up my animations here. That's not supposed to be there. But I'll kind of put these all here next to each other. So these are just the different areas that are knocked out and why you get certain symptoms. I was going to go into a little more detail on this because I actually found it really interesting, but I'm running out of time. So unfortunately, I'm going to have to skip through. But if you want to more for the Brown-Séquard, I always thought it was funky how some are ipsilateral, some are contralateral. Why is that? There is a whole reason. The quick reason is it depends where the nerves cross over, where they decussate, whether it's in the brainstem or in the spinal cord, but I'm not going to go into detail. I'll try to go through the last two pretty quickly. Okay. 27-year-old male brought in by EMS after a motor vehicle collision. Per EMS report, patient was riding a motorcycle when he lost control, hit a car and was ejected 20 feet from the bike. He presents to the ED. He's saying words, but they don't make sense. He's not answering questions. He's not opening his eyes when you ask his name. You sternal rub him, which causes him to open his eyes and withdraw from pain. What is this patient's GCS? This is something that I've seen on so many tests, and every time I get it, I'm never confident, and I feel like it's easy points, so I figured I would throw it in here. 8, 9, 10, 11, 12. How many for 8? How many for 9? I know it probably takes time to like sit and think through it, but I'm going to rush through it, unfortunately, so I'll go over it. 10, 11, or 12, I'll just kind of say, so it's 9. So this is your Glasgow Coma scale. Oops. So he's saying words, but they don't make sense, and he's not answering questions. That's inappropriate responses, but the words are discernible. He's not opening his eyes. You sternal rub him, which is a noxious stimuli, which then causes him to open his eyes, which is your eyes open to pain. So it's another 2 points. And then he also withdraws from the pain when you sternal rub him. So that is another 4 points. So that's how you get to 9. Last question, 45-year-old male, history of hypertension, hyperlipidemia, schizophrenia, brought to CCT due to concerning vital signs, temperature 104, heart rate 120, respiratory rate 30, 95% on room air, BP 170 over 99. Brought in by family members who said he seemed confused, isn't talking much, and he's been sweating. All of which have been worsening for the past 3 days. He's been compliant with the schizophrenia medications, and family denies any recent episodes of psychosis. Denied nausea, vomiting, diarrhea. They are concerned that he has an infection and are wondering if this could be COVID. On exam, he is awake but not answering your questions. He appears profusely diaphoretic and very stiff. When you examine his extremities, the muscles are hypertonic and difficult to move. An IV is placed and labs are drawn. What is the next best step in management? COVID test, a CT chest, Tylenol and discharge home. Shout out to Dr. Sinner. Lumbar puncture or IV fluids, cooling blankets, and cardiac monitor. So how many for A? B? C? D? Or E? Yeah. So this is going for neuroleptic malignant syndrome, most commonly due to high potency first generation antipsychotics. So I kind of went through all of them in this slide. Some are first gen, some are second generation, which can cause it. It's just more common in the high potency first generation, and then a couple antiemetics as well. I'm not going to go through like a ton of details, but there's a tetrad of symptoms: altered mental status, muscular rigidity, hyperthermia, and often associated with profuse diaphoresis and autonomic instability. Diagnosis is primarily clinical, and labs and imaging. There's no diagnostic test, but you can do them to rule out other causes and to monitor for complications. There is a scoring system, but it is not validated. It just kind of exists to kind of give you an idea of what symptoms to kind of think about. Really quick, treatment, you stop the causative agent. For NMS, it's primarily supportive care. That's not to mean you won't give other medications if you need to control their blood pressure, oxygen supplementation, if they have arrhythmias and you need to control arrhythmias. So it's not saying you're not giving any medication, but there's no specific antidote for the NMS. Some people anecdotally will give benzos, dantrolene, bromocriptine, and this is one if you have diagnostic uncertainty, but also there's some anecdotal evidence of efficacy. I won't go into detail of this, but just a reminder that these three conditions can overlap a lot. They have a couple things that kind of may be more suggestive, but a lot of the time it's in the history, knowing what the triggering agent is. Yeah. And just a reminder, we have a malignant hyperthermia cart and CCT and 3 left. Dantrolene, I believe, is in the first drawer. Huh? Okay. Just on time. Any questions? Yeah. Yeah. Lots of animation, sorry. That was question 2. There we go.
So I think this is the old classification.
Oh,
I think I heard the simple, complex, categories thing.
yeah. If that's the case, then I apologize for talking about older classifications. This was discussed in Titanelli, so then I just kind of like dug into it. But I didn't, I guess, dig enough to realize that there was a more updated. Any other questions, comments?
Great. You're gonna send this all out, right?
Yeah.
Right, especially this, it's great, so much work into it.
Yeah, that'll be sent out right after conference with all the answers on it. All right, thanks, guys.
Thank you.